Good afternoon, everybody. Hello, I'm Ina Jooste. I'm with the Bhekisisa Center for Health Journalism, and thank you so much for joining us for what I think is a really fascinating topic of discussion. Today, we're asking a very simple question with a very big answer. The question is, what does climate change have to do with HIV? And it turns out quite a lot. Across South Africa and in the region, we're seeing more floods, more heat waves, more droughts. And then when these disasters hit, people move. Homes wash away, livelihoods are destroyed or collapsed, and families often have to start over somewhere else, somewhere new with very little on them. But people don't all arrive in places on the same and on an equal footing. For someone living with HIV or someone who might be at risk of HIV, being displaced can mean losing the clinic they know, losing the doctor or support network that they know, or suddenly being in a space where they just don't know where to get treatment. It makes it much harder to stay healthy. And this is happening at the same time as HIV programs are dealing with some of the most radical cuts we've ever seen. At a recent, the UNAIDS warned recently that this is a problem that will only get worse. At the same time, COP30 has just ended with a really mixed outcome. There's no firm global deal on moving away from fossil fuels, but there's some good news on the funding front. And this is why we're here today. These are two huge crises of our time that are actually colliding. With World AIDS Day coming up, this is a moment for journalists to explore new angles and to connect two global stories that are often told separately. They're both difficult and important stories to tell, but that are increasingly shaping each other. HIV shaping, or climate change shaping HIV, shaping how we think about it, and definitely shaping people in their daily lives. We're very lucky to have two experts here who work right at this intersection. So thank you for joining us, to Chris Jack and Kokeka Nogutuka. Thank you for everyone on the line for joining and for being part of this conversation. It's an hour and a half long webinar, so it'll go like this. We'll briefly get to know each of the two speakers just to get a taste of why they do what they do. And then they'll each present their area of expertise in greater depth. We'll have a conversation with them. And thank you for all the questions that have come in the registration forms. And do keep posting questions in the chat, because there'll be ample time to put questions to them and for our two experts to answer those questions, because it's an hour and a half. So I think with that said, we'll dive in and ask you both. Let me start with you, Chris. Why do you do what you do? It's a very complicated subject. What drives you? What fascinates you about this area? And
Great.
tell us a little more about yourself too, and where you work, and all of the usual introductory stuff.
Thanks, Ida. Thanks for the introduction. Yeah, thanks. Good to meet everybody. Yeah, my name is Chris, and I always introduce myself as a climate scientist, though I'm not always sure that is what I am anymore. I work at the University of Cape Town, where I co-lead the Climate System Analysis Group. And I also have another role as a science lead advisor for the Red Cross Red Crescent Climate Center, which is an organization that provides climate science guidance and expertise for the international Red Cross movement. So we do a lot of work around humanitarian support in climate crisis. My background is actually in computer science. So I started off, I've always wanted to save the world in some way. Even as a child, as a teenager, I was very concerned about the state of the world. And then I discovered computers and thought computers were the way to save the world. So I dived into that, only to realize that they may not be the way to save the world. And ended up doing a degree in computer science and climate science, because climate modeling seemed to be a really, at that time, growing phenomena, and really critical to understanding how the world might change into the future. So I spent many years running climate models, trying to project how the climate might change, particularly over South Africa and Africa. And then, to be honest, I got frustrated because we did a lot of science. We produced a lot of reports, a lot of maps, a lot of complicated diagrams, but we weren't seeing any change. We weren't seeing decision makers making different decisions. So I became really curious. I guess what drives me is concern and curiosity at the same time. Concern that we're not seeing changes, concern that particularly vulnerable people are increasingly impacted by climate change as well as many other drivers and issues. And frustration, yeah, that we're not seeing changes. So I really dived into why are decisions not being made? What would it take to make decisions? What kind of interventions might work? And so most of my work these days is trying to dive through the complexity of how climate intersects with all different kinds of issues. And then how do we navigate the decisions around that? And so my wife often teases me that I'm becoming more of a social scientist than a natural scientist. So the complexity really intrigues me, but again, it also really concerns me because I think we're not prepared. We're going to experience impacts that we didn't think we're going to emerge. So the more we can think about these things and particularly think about the complexity, yeah, the better. Climate and health is relatively new for me the last 3 or 4 years. And I'll talk more about this in a moment. But to me, the intersection of climate health is the archetype of complexity and difficult decision making. There's so many things that come together, as many of you will know. And so that's where I find myself at the moment. I'm very glad to be here. Thank you.
Thank you, Chris. I really we all look forward to hearing more from you and how to bring all of those pieces together without making it too complex for ourselves as journalists to understand, and obviously the people who read our stories. Kotreka Noguduka, I'm also so thrilled that we have you here today. You're currently consulting for the Department of Health, the National Department of Health in South Africa, and over 20 or more years you have worked for UNAIDS, for PEPFAR, for SANAC, the South African National AIDS Council, all of those major bodies that have to do with HIV and other health aspects. So I know you know them all inside out and also how they intersect. And I really want to know what has been the sort of thread in your life and in your career about why we should be, 40 years later, more than 40 years later, why we should still be concerned about HIV.
Thank you very much, Ida, and good afternoon, colleagues. So yeah, as you have indicated, I've worked in the HIV space for more than 25 years now. And the challenge with the HIV response is the more effort and the more resources we are putting in the response, the slower we are reducing new infections. And as we look deeper into what are the drivers of new infections, what are the drivers of the diseases, we then got to understand that from the olden days, I think we've all been aware of the conversation that was saying HIV was a social issue more than a person-specific disease. So as social issues and social determinants of health are changing, the vulnerabilities to HIV continue to increase over years. So as we have seen different conversations, different agendas that are coming up, we all know that before we focused more on climate change, we were focusing on pandemic preparedness post-COVID-19. We've seen how HIV was impacted, the HIV response and the HIV spread was impacted during COVID. And it became clear that any other pandemic that would then emerge would have an impact and reverse some of the gains that we've made in our HIV response globally. But also as conversations were starting and there was concrete evidence around links between climate crisis and health, it became clear that within the health component, HIV also had to be looked at because we are again seeing increasing incidences around HIV, and those are not necessarily driven by, as much as they are driven by individual choices, but there are certain social determinants of health that are driving people's choices that put them at risk of acquiring HIV. So my interest is now looking at how these impact your pandemics, your new pandemics that are coming up, your climate change that is emerging. How are these contributing in driving HIV? And I think you've said it, Ida, at the beginning of this conversation, that global health is in a crisis. Financing and sustaining programs is the agenda of the day. So we need to rethink what the HIV response looks like. It's not as simple as it was a couple of years ago, because within the climate change context, which impacts on social determinants that contribute to the HIV response. Therefore, we have a responsibility to adapt our response to be aligned with the emerging crises that are coming up. And also, as you've indicated, as journalists, then we have a responsibility to update our reporting frame to contribute to or to drive the current conversations in terms of how then the climate change contributes to the HIV response, or how is the HIV response have adapted to incorporate some of the climate change adaptations that the different sectors are working on. Thanks, Aida.
Thank you so much. Look forward to hearing more, and especially hearing from you how we explain a concept like the social determinants of health, which is a word that people who work in that area, or a phrase that people who work in that area may use often, but it's something that we might need to explain to our readers, and I'd love to hear from you how we do that. But we'll get to you to a more in-depth look at your work a little later. We're going to go to your PowerPoint now, Chris. You've prepared a presentation to help us understand climate change, the modeling, and also, again, help us tell those stories. Thank you.
Great. Thanks so much. Yeah, really good to have those introductions. And I think it set a really good scene for the conversation now. Yeah, as I said at the beginning, I'm a climate scientist, so I'm going to approach this very much from the climate science angle, and also from an angle around complexity. But as Ida has already indicated, we need to figure out how we can think about complexity in ways that are simple, not just for communication, not just for journalism, but for decision making and for all of our engagement with these issues. So let's see where we go with this journey. So yeah, climate change and people on the move is the title we provisionally gave my presentation, but I also added in there or not, because the more I thought about what I want to talk about, I think we need to have quite a broad perspective on how climate change impacts HIV. Okay, let's dive into this. I have to start with my slide's a little bit wrong there. I lost a bit of the heading, but that's fine. The climate change is a global story. So this is a story that we're very familiar with, and everyone here will be very, very familiar with. And the graph on the right is a very familiar graph for many of us. Global temperature increase from the 1860s, what we call pre-industrial times, through the 20th century and now beyond that. And the key message here, of course, is that the world is warming. Things are getting warmer consistently. This is not disputed anymore. It's very clear that the world is getting warmer. And that 1.5 degree line at the top there is the threshold we've been kind of aiming at for a while. It's been the topic of COP negotiations for many years, trying to avoid 1.5 degrees of warming. This is the big global story. And of course, behind the story is global emissions, carbon emissions, and the seeming huge challenge of reducing those emissions to reduce this rate of warming and perhaps at some point stop the warming. So this is the big global story. We will burn past 1.5 degrees warming. As a scientist, I'm always meant to be cautious and have a lot of caveats and uncertainties. I think this is the point where we can say there's no question we will go past 1.5 degrees warming. So it will be in a matter of a few years, probably by the end of the decade, we will be in a post 1.5 degree world, which is a world that we've spoken about for a long time. We've thought a little bit about what it might look like, but now we really have to plan for the impacts of going past 1.5 degrees. Coming out of the last COP, this recent COP, yeah, the hesitance to reduce emissions, I suspect means we'll go past 1.5 and possibly easily past 2 degrees later on in the century. So this is locked in. We don't really have a choice. We have to think about dealing with the implications of ongoing warming past 1.5 and probably past 2 degrees, and think about how we're going to deal with those impacts. Yes, of course, we have to keep mitigating. We have to keep reducing emissions, but fundamentally, adaptation and resilience is not an add-on. It is really essential. So a lot of the work that we're doing now is really trying to understand what does that mean how do we do these interventions, and understanding the complexity of it. Climate risk is a different term. So climate change is this global story, the world is getting warmer. Climate risk is, again, starts becoming more complicated because climate change compounds with natural extremes. So Ida, in the introduction, you spoke about increasing droughts and floods in Southern Africa, which is true. But if we look at things like this is the trend in ocean temperature across the world, where we would expect it to be getting warmer everywhere. We see some areas, like the Eastern Pacific Ocean, that over this particular period have actually got cooler. And the reason for that is many years of strong La Nina conditions. You will have heard about El Nino and La Nina. So we have this natural variability. We had a number of years of very strong La Nina conditions, and that cooled the southwestern Pacific Ocean for quite a few years, which has actually reduced the trend to a negative trend. The point of this slide is not to talk about El Nino or La Nina. It's really to say that there are natural cycles of wet and dry, there are natural cycles of hot and cold, and climate change compounds with these natural extremes. So we've always had droughts in Southern Africa. Climate change is making those droughts hotter, and a hotter drought is a drier drought with bigger impacts. We've always had extreme rainfall events in Southern Africa. Climate change is making those extreme rainfall events more intense and in some places more common, or more likely. So we're dealing with what's happened always, natural variability, and now climate change is beginning to compound on top of that. Climate change magnifies those extremes. So we get more intense rainfall events. I was just last week on a podcast talking about Hurricane Melissa that hit Jamaica and the Caribbean, and how that was a far more intense event because of climate change. And in fact, in some cases, we're really experiencing these unprecedented events. And this is really important. It's not just dramatic. It means that we're experiencing events that we've never in recorded history experienced before. We often build our systems and design systems and think about the future by looking back and seeing what we've experienced in the past. That's no longer a good assumption. So we have to start thinking what might happen in the future that we haven't experienced in the past. So again, Hurricane Melissa turned into a Category 5 hurricane, which for Jamaica was an unprecedented event. And so this has all sorts of implications as we think about these complex interactions, and particularly around climate and health and climate and HIV. So climate change is a global story. Climate change compounds with natural extremes. And then what I really want to emphasize and talk about more today is the climate risk is a global to local story. We talk about this big picture of global warming. That's often the narrative. That's often what's in the news. It's global warming, struggling to reduce emissions, COP30, negotiations. But where it really hits the ground is at the local level, where people are impacted, where livelihoods are disrupted, where people's health is disrupted, the economy is disrupted. So the whole time we're trying to link this global story down to what does it actually mean at the local level for real people living real lives. And that's where we've actually failed a lot in climate science, coming from the natural sciences, and where many climate scientists and social scientists are trying to flip the picture around and really trying to understand it from the bottom up, as it were. So compounding, cascading, and complex. So I hope this is going to get a little bit complicated, and then I hope we can bring it back to simple. So I did just want to emphasize this framing of compounding, cascading, and complex, because this is a dominant framing that we're working with more and more these days as we try to understand these issues. What it's really getting at is that it's seldom about that first order impact. So when we have an extreme flood event, we get extreme rainfall and it floods. That, of course, is an impact in itself, but it's seldom just about that. Flooding damages roads, is a key impact that often comes out of flooding events or other types of infrastructure. But of course, that actually compounds with non-climate drivers. So often we have inadequate infrastructure. The roads are not built well, they're not maintained well. The bridges aren't constructed, designed for extreme rainfall events. So those things combine to produce damaged roads. That trend results in limited access to healthcare. This is a very common outcome we see, particularly with tropical cyclones in East Africa. After the event, people are unable to access local clinics. But that also often compounds with low health system resilience or poorly designed health systems or weak health systems. So non-climate driver now compounding with this climate impact. We call these pathways. And all of that can result in negative health outcomes. So it becomes a much more complicated picture of things that are compounding with each other. So climate drivers compound with other climate drivers. For example, we often get an extreme rainfall event that actually then compounds with high temperatures after that event, compounding with non-climate drivers like poor infrastructure or weak health systems. And then these cascade through the system, through infrastructure, through access to healthcare, through health outcomes, and then beyond that into livelihoods, loss of primary breadwinners, through to education. So these are the complex cascading impacts that emerge. And when we have this complexity, we end up with these large uncertainties and things emerging that we didn't anticipate. And I think that's really what we're starting to see with climate change and HIV is unexpected outcomes. We thought that we were in some ways managing to manage HIV infections, and now we're seeing something emerging that is perhaps challenging that. And of course, it gets super complicated. So I just threw this in to show you how complicated it can get. This is some work we did around climate and health and other issues of security, and where we mapped out all these different issues and how they connect, forming these big complicated networks. We've now got to the point of saying, I'm not sure this is very useful because it's just too complicated, but it's interesting to see how complicated it can get. And this was just done with desktop review of literature and gray literature and technical reports and so on. This wasn't even interviewing people, which we should have done. But it can get very complicated very quickly. But what I will do is just dive into to highlight one thing that came out of this work. This was focused actually on Southeast Asia. And many of the countries we looked at, the same kind of issues came out of migration and precarity. So climate impact in many different ways, but ultimately for the most vulnerable, what it results is in increased precarity, so precarious livelihoods, precarious social conditions, and in many cases that results in some form of migration. And of course, migration or displacement is complicated. Sometimes it's seasonal, sometimes it's long-term, sometimes it's just the head of the household that migrates, sometimes it's a man in the house that migrates or moves somewhere, sometimes it's not. And there's lots of issues around migration, which I'll get to later. But it was so interesting that this issue of displacement, migration, and precarity was so consistent across all the countries that we looked at. And then zooming into another part of that map, what really came through, this was always at the end of the chain, if you like, was vulnerability. So really what we're seeing is that climate change is increasing vulnerability to shocks in many different ways. So threats to livelihoods in this particular case, but all sorts of drivers of increasing vulnerability. And unfortunately, what we ended up with in many of the countries, actually all the countries, was clear indications of increasing vulnerability to human trafficking and vulnerability to sexual exploitation, which of course is not the only link into HIV, but is a very key link into HIV. Yes, a lot of complexity, but fundamentally the message is very simple. The most vulnerable are the most impacted. They end up in much more precarious conditions, and in some cases that results in displacement and migration. And all of this wraps up in increased vulnerability, which drives many of these alternative livelihoods or alternative options or choices that are made. So in some ways, very complex, but potentially simpler as well. Okay, so just more formally thinking through, and I know there's been a lot of reports on this, and this was just me trying to consolidate some of that, some of the climate and HIV pathways. And of course, it's more complicated even than this. But we have climate change and climate variability on the left, resulting in what we think of as climate shocks. Mostly we think of climate shocks as the big extreme events, the big flood events, the displacement of people through tropical cyclones, the big drought events that might have similar kind of impacts. But I also want to emphasize that a lot of climate impacts come through smaller events. They're not necessarily the big events. So we're doing a lot of work in the city of Cape Town at the moment, looking at climate and health in informal settlements in Cape Town. And there we're not talking about big tropical cyclones because we don't get that. We're talking about the chronic flooding that happens every winter season in Cape Town and the impact that that has on vulnerable communities. So they're not the big shock events. It's very much the chronic, almost day-to-day kind of lived experience of climate and weather in those conditions. And what we're understanding is that it has a similar impact on household and a similar impact on health, even as the big shock events in many cases. So it's important not just to focus in on those big events. Anyway, we have these climate shocks, and that produces all sorts of primary impacts. I've put insecurities there because there are food insecurities, there's water insecurities, there's livelihood insecurities, there's actual physical insecurities that result when your house is damaged and you're living out on the street. You have a lot more physical insecurities. There's damage and access to health systems is a key one. There's poor water access. And then there's the increase of other diseases. So we're already seeing increasing prevalence of malaria in some places that have not experienced malaria before because of increasing temperatures. There's some links in some places to increasing cholera outbreaks. Many other infectious diseases are on the increase because of climate change. Again, that's a longer term trend that may not be directly related to the shock. Insecurities, as I've mentioned just now, often result in migration and displacement. And then we end up with vulnerable people remaining. So I want to highlight on the right there, what I understand is the three parts of migration. Yes, we have people leaving, but often those people also remain behind. So who remains behind, and often their vulnerability is increased. If the man of the house migrates to different opportunities and leaves behind the woman-headed household, that often increases the household vulnerability, or the other way around. Then we have vulnerable en route. So increasingly, we're seeing people that are displaced and en route are also impacted by climate, whether that's droughts, lack of water, flooding, and often end up in displaced camps in very vulnerable conditions. And then vulnerable to the destination. So this is really interesting, the work that we're doing, particularly in urban climate and health, is people who are migrating to the city, which is a very common occurrence in Africa in particular with rapid urbanization. And again, that migration could be for all sorts of reasons. It's generally not just climate. It's often economics and climate and seeking opportunities, hopes and aspirations, all sorts of reasons why people move. But when they arrive in a city, they're often in a vulnerable position with very little resources and accommodation. And so they have a very unique vulnerability. If those people are also HIV positive or have other diseases or health issues, they can often be ostracized, particularly if they come from another country. So we're talking about a very, very vulnerable community, often in these urban contexts. And of course, this vulnerability combines with things like poor water access and other diseases and disrupted treatment and many other drivers increases the morbidity and mortality. So that's a simple, quote unquote, picture of how climate and HIV pathways may intersect. Keke might present a different perspective on this later. I hope she does, so we can have some good discussions about it. Just wanted to highlight the work we are doing on climate and health. I'm not sure where I am with time, but I've lost track a little bit. But I wanted to highlight it not just to promote what we're doing. This is a project called Cascade, looking at cascading climate and health risks in cities across 5 different cities in Africa. But the reason I wanted to highlight it is because the framing that we took, I think, is really important. Instead of just looking at how climate impacts health in cities, we felt that we really needed to take a more holistic approach. So we've broken it up into these 3 research clusters. And the first one is these climate health risk pathways. So how does climate really impact health? And I want to emphasize the really, because the more we dig into it, the more we realize how complex and cascading these impacts are. And many of it comes through this idea of social determinants of health. So it's not that primary impact that you experience a flood. It's perhaps that chronic flooding that disrupts your livelihoods, that limits your children's access to schools, all sorts of things that become the social determinants of health. So complex and cascading pathways. And here we're really emphasizing the need for analytical alongside narrative. So we can look at data, we can look at statistics, but we also need to be listening to people's stories, people who are actually experiencing these issues, so that they can help us understand how these pathways work and also what the interventions might be. Which takes me to the next point, which is what interventions really work. We've seen lots of little pieces of work done to adapt to climate change, perhaps building a drainage here, or putting up solar power here, or changing something here. But which of those really work? And going beyond single sectoral responses, we need to be understanding how do we intervene across the system. So it's not just the health system, but it needs to bring in the social system, social protection systems. It needs to bring in education and health and economics. How do we do these interventions? And part of that is talking to people again, actual people who are experiencing these impacts and trying to understand from them what interventions would really work. And then really the critical one, and this is where I'm learning the most at the moment, is how are climate and health decisions negotiated? Who actually ends up making decisions that result in these interventions? How are those decisions made? Where's the power in those? And how do we lift up particularly the marginalized voices that are often not present in those negotiations and those discussions? And of course, finance comes into here, and many other things, including international development programs. So it's a very complicated space. But we're finding that if we don't understand the governance side, we can understand the science as much as we want. We can have the most amazing interventions on our tables, as we might imagine. But if we don't understand the governance side of it, then nothing is going to be effective. So that's the approach we're taking in Cascade. And I think it goes beyond just the urban climate health and very much would connect to climate and HIV. So my last slide is really what I often want to emphasize is the invisible and silent stories. So the data-driven approaches are really important. And just a little side note on data, because I'm here. Data always comes up in these discussions. The lack of data, the lack of difficulty in accessing data, and particularly health data. We've been in a project now for 4 years where we've been trying to consolidate health outcomes data across a number of countries, and we're just making a little bit of progress after 4 years. There's a lot of challenges around data. So if there's a story we need to be talking about, it's around health data and research. But that data-driven approach also has risks, and it risks, to me, hiding and silencing the stories. And the more I've begun to hear those stories of people who live through these different experiences, who have different health challenges, impacted by different climate shocks, the more I realize how the data-driven approaches are often hiding and silencing those stories. Not in a malicious way, it's just a different way of framing things. There are many unquestioned assumptions that we make in our data-driven approaches, in our nice graphs and plots, assumptions that are not true when you start digging down again to those lived experiences. There are hidden vulnerabilities and risk pathways. We don't understand well enough how people experience these shocks, what their responses are. One thing is we often think of them as very vulnerable and passive if they're experiencing a shock and they're vulnerable people. Whereas actually often there's a hidden agency and there's opportunities. Often people experiencing these conditions, yes, they're vulnerable, they may not have the resources, but they often have ideas on what the intervention should be. And they often have the convening power to bring groups of people together, bring communities together, and push for change. So that's something I really think we need to leverage. And what often results out of not doing all of this is ineffective interventions. So I'm going to end off by circling all the way back to Ida's comment that COP30 resulted in some progress in climate finance. So potentially the EU, whether they wanted to or not, committed to more climate finance. But what do we do with that finance? And what worries me is it can easily be thrown away at very ineffective interventions. So I'm going to end it there. We've come a few circles. I hope that's useful, and I'm very keen for the rest of the conversation. Thank you.
Thank you so much for that, Chris. Really incredible. Really have to compliment you on how you've taken these complexities and nevertheless given us, the simple human story that matters. Journalists often, I heard words like complexity quite a few times. You yourself acknowledge that these issues are complex and the compounding issues and the cascading of issues. Often what happens to journalists when they hear such fascinating talks is the next step is to go to their editor and say, I heard somebody talk about this, and this is why it matters. Could you help us through that conversation if we were to speak to an editor and say, this was a fascinating talk. we ought to tell our readers about it, what would they say to their editor?
Now you put me on the spot. Yeah, I think what I often end up telling people is it's very tempting to try and avoid the complexity and the cascading. Let's just call it the complexity. It's tempting because it's overwhelming, and we're not sure what to do with it. I think we need to be embracing it. And the reason why that's so important is because we've failed to embrace complexity for too many years. And the result of that has been what I ended on: ineffective interventions, misunderstandings, and critically, again, vulnerable people not being helped. So yes, it's complex, but we have tools, we have ways for understanding it. We can come down to these lived experience stories. We can lift that back up to a bigger picture. There are ways of dealing with the complexity, but not dealing with the complexity means fundamentally that the most vulnerable will continue to be impacted. I don't know if that would sell to an editor. I'm not a journalist, so.
Thank you. But I know you said that journalists can contact you to help us unpack that complexity. And we'll get to more of it during this discussion. Bhekisisa, we go to you now. I'm so looking forward to hearing what you have to say, because many times when Chris spoke, I recalled previous conversations that we've had, and also what you said in your introduction, is that there are very many areas where your areas of work overlap, but you also have a very specific zoomed in focus on HIV, TB, and other concerns in the health field, but also the health system itself, the health system being the clinics, the hospitals, the health workers that people desperately need to get to in crisis and not in crisis. So please give us more of your expertise. Thank you.
Thank you very much, Ida. So I've realized, Chris, that some of our talking points are overlapping. So I will not repeat some of the issues that Chris has addressed, but I will try and cover some of the specific issues around HIV in terms of climate crisis. Next slide, please. I think, colleagues, we've had the conversation from Chris and from Ida around the COP30 that was hosted in Brazil in November. And as much as we've seen some of the COP30 work building from the Paris Agreement, we've seen also that some of the results around the conversations were not as positive as we've wanted them to be. But I think we soldier on and we continue to fast track implementation, and we continue to ensure that the conversations continue. And also, I think what is clear from the conversations that we are having is that climate crisis is not a distant specter looming in the near future. We are already starting to see adverse effects and its impact on health already. So these conversations are no longer future conversations. They are conversations that are informing our public health response in the current times. Next slide. So in terms of my introduction, I just wanted to emphasize or put a disclaimer to say, based on the research and the conversations and the policies that are out there, the work that has been done and documented is how climate crisis impacts on health. But HIV has been under-recognized. Therefore, we have a responsibility to highlight that. So over the past 2 years, we've done some work to make sure that HIV work is then recognized under climate change and climate crisis. But what we need also to understand, so that as we are reporting our stories or as we are driving conversation, is that climate change does not directly influence the virus itself, but it then generates or influences the environment and the social systems that then impact in transmitting the infections, as well as then putting people that are already on treatment in danger. So I think we have to be careful when we are crafting our conversations, also when we are having those dialogues, that we do not say there's a direct influence, but the systems and the environment that is influenced, that then drives the new infections. Next slide, please. So I think Chris spoke a little bit about research, but also I wanted to touch on some of the evidence on the research that is out there. Some of the research in the sub-Saharan Africa shows that between 11.6 to 16 million additional new cases of HIV infection will be seen by 2050 if our temperature continues to rise. And another study also in Africa has shared findings that HIV infections rise by 11% after every drought in the HIV endemic rural areas. So those rural areas that have already high HIV prevalence, every drought we're seeing in new infections rising in those areas. Also, heavy rainfalls have been also documented that there is a correlation between heavy rains and increased new infections. So that's evidence that is out there. That means that the work that we need to be doing really needs to focus on climate change. So just quickly, in terms of how climate crisis impacts on HIV, I think we have spoken, Chris has already covered quite to some level issues around how the weather events lead to humanitarian crisis, especially issues around displacement, and how displacement then also accelerates poverty, increases vulnerability, which then also increases HIV infections and have adverse effects on people that are already living with HIV that are already on treatment. And I think we have already seen how HIV has been exacerbated in areas that have high humanitarian crises, especially up in the African region. So as soon as then there's a human crisis, we've seen that HIV incidence increases. Then if we are saying then climate crisis contributes to humanitarian, therefore then it means then HIV infections will then be increased. We've also seen that the core infections, TB as well as malaria in malaria endemic countries, which are leading causes of death and have serious impacts on communities that are living in some of these vulnerabilities that we have mentioned, areas of poverty, areas of displacement. And we have seen that those are the same populations that then get affected by climate change. So climate change worsens people's situations across the different spectrums of the socio-economic impacts in people's lives. We spoke about migration, that as people migrate, they lose their homes, they change health facilities, which can then also impact on their HIV treatment. When they are displaced by extreme weathers, their homes might be washed away with their identification documents, and they might not even be able to get into a new health facility and be able to identify themselves so that they can be then re-registered into our public health systems. And we also seen that in AIDS-affected countries, lack of investments around trained personnel, around health infrastructure, including medical supplies, also dilutes the capacity of the health systems to then be able to respond in case of a climate crisis. Next slide, please. And we've also seen that in terms of migration or displacement due to, in this case, climate crisis, people that have been displaced or people that are foreign in certain areas are not always opened with open arms. When then there's discrimination and marginalization of these displaced populations, we see vulnerability increasing. And if we then include HIV stigma and HIV discrimination on top of displaced populations, it then becomes difficult for those populations to even access health services or even to be able to disclose their HIV status, which then also exacerbate opportunistic infections, as well as also exacerbate the spread of new infections within that particular community. And people living with HIV we'll see them suffering from a disruption of ARV treatment. As I've indicated, if your health facility is then destroyed due to climate crisis, or if you are then displaced, you might then not be able to access your treatment in a new facility. And also sometimes we find that people have nutritional needs that are being unmet because they have been displaced and they have moved to other places. Next slide, please. If we're looking at interconnected pathways, I think Chris has touched on this topic in terms of how there is interconnection between the pathways that link climate crisis and HIV and health. So in this case, if we're looking at erosion of the health infrastructure, weather-related disasters can erode our public health infrastructure physically, as well as disrupt the healthcare system by destroying, for example, medical records, medicines that people would be getting, as well as the provision of services. So also weather-related crises might mean that our staffing or healthcare workers have to leave their communities for the same reason that other people would have lived. Then that will then be impacting on the capacity of that in particular health system infrastructure to provide health services. Increase in diseases, I think also Chris has touched around this in terms of outbreaks. If you've got high rainfalls, we may have waterborne disease outbreaks, vector-borne disease, as well as foodborne disease, which will increase vulnerabilities amongst people that are already HIV infected and around people that are already on treatment. Issues of food security. During disasters, food production is affected either by flooding or by high drought situations, and that diminishes the crop yield. Therefore, food security becoming a crisis, and we all know and we're all aware that our patients that are on treatment require food for them to be able to take the treatment that they are on. We had touched around issues of economic stress, that during a climate crisis, communities are vulnerable to increased economic stress. I mean, water scarcity alone, that is exacerbated by the climate change, could mean that there's high payments around water. It means that there's lack of water supply, which then has a direct impact on our patients when they have to take their treatment and also maintain the public health regulations around washing your hands. Those interventions become affected because then there is no water in that particular community. We've spoken a lot about migration, but people that are migrated forcefully or migrated due to a weather crisis are also impacted in terms of access to health services, but also in terms of continuing their treatment. But also, I think Chris has spoken to the vulnerabilities of people being in areas that they are not aware of. They are unable to continue with their economic activities, and then they will opt for sex work. Others will then be engaging in drugs and substance abuse, which then will put them more at risk of new infections. So the pathways that connect and link to climate crisis do have direct impact on our HIV response, both in prevention and treatment and care and support. Next slide, please. So just to say that also, how the climate crisis impact on different populations in terms of the HIV is driven both by the persons, that is in terms of their demographics as well as their socioeconomic status, but also to where the person is in terms of their geographic coverage as well as the strength of their health systems. So these are both important when we are thinking about how then do we respond, or how then do we make sure that we put systems in place to prevent impact or to reduce the impact of a climate crisis on our AIDS response. Next slide, please. So in terms of the social determinants of health, as we define social determinants of health, it also includes gender, sexual orientation, socioeconomic status, age, demographic factors, culture, religion, literacy, race, ethnicity, as well as geographic location. So all these social determinants, they drive the response to health. They will drive who gets HIV infected, who gets HIV tested, and who has access to treatment. And for those that are on treatment, who can then adhere on treatment and remains healthy for the longest. So it is important that when we're thinking about the solutions and how do we adapt our HIV response to be resilient on climate crisis, we also make sure that we look at the social determinants of health and we are able to address social determinants of health specific adaptations so that our populations or our communities can be able to benefit from the systems that we are putting in place. There's evidence that the social determinants of health can magnify outcomes relating to both HIV and the climate crisis, and populations that are most marginalized are disproportionately affected by the climate changes in terms of how then they respond to our HIV interventions. Next slide, please. Also, when we're talking or looking at the capacity and the resilience of the health system, the capacity of the resilience of the health system makes a huge difference when it comes to climate consequences. If the health system has already put in place adaptation measures to encounter weather disruptions, then it becomes easier for that health system, one, to continue the services during a climate crisis, but also to be able to bounce back and be able to provide services post whatever crisis that has taken place. So health facilities or the health systems in terms of responding in South Africa have been looking at alternative systems in terms of making sure that there's power backups, making sure that we're going to green energy, making sure that there are alternative water supplies in our health systems so that we can be able to circumvent some of these climate consequences. The issue also of around the resilience of the health system talks to issues around supply chain, talks to issues around location, talks to issues of being able to adapt in terms of making sure that services can be implemented or communities can be able to access services, not necessarily in a mortar and infrastructure. So if the clinic gets to be washed away, are we still able to provide health services for those communities in the absence of the physical infrastructure of a health system? So those are the issues that we need to think about when we're talking or when we're thinking about the resilience of a health system to be able to continue providing HIV services in an event of a climate crisis. Next slide, please. So here I just decided that let me summarize to say, as journalists, how can we address the link between climate change and HIV? Here we need to start focusing on how climate change affects our health or our HIV response in terms of food insecurity, migration, reduced agency in terms of ensuring that there is sufficient human rights response to our HIV response. So we also need to be able to humanize the crisis. So we need to use methods like digital storytelling to be able to share the lived experiences of those communities that get affected in the event of a climate crisis. We have to be able to hold institutions accountable. As journalists, we have the responsibility to be able for policy change, to be able to highlight policy gaps, and also to be able to ensure that impact on public health and HIV services is not overlooked when we continue to address climate change solutions. We have to be able to promote solutions. We have to be able to be reporting on initiatives that address these intersections. We have to be able to support some of the conversations around how these initiatives are then working in certain communities and see how we can be able to learn from what has already been implemented and already work. So we have to be able to make sure that we tell also positive stories as an outcome of a response out of a climate change and HIV. Next slide, please. So in terms of our contribution to the solutions, as journalists, we have to be able to continue creating spaces for dialogue, to broaden the conversation, but also to deepen the understanding around the practical adaptations around HIV response and climate change. We have to use the best evidence available to increase awareness for our stakeholders, especially communities that then consume our news, for us to make sure that the potential impact of climate change on our ability to end AIDS continues to be addressed. We have to be able to identify, cultivate, and scale best community-level adaptations around HIV and climate change, and be able to continue these conversations when we are reporting on weather on TV. We have to make that link to say in Gqeberha it will be 38 degrees, and what does that mean for a person that is on treatment? What does it mean for a woman that is pregnant in terms of making sure that they remain cool? They're also able to drink water so that they prevent some of the health consequences. We have to be able to continue reducing our own climate footprint. So also as a journalist community, we have to contribute in reducing our own climate footprint as we continue to either to deliver the news, but also as citizens of the country, we also have to contribute to the solutions. Next slide, please. So in conclusion, I would want to say that as the climate crisis threatens to significantly increase the number of people affected by HIV, therefore we cannot afford to lose the gains that we've made in our endeavor to end AIDS by 2030. So we have to make sure that in the conversations around HIV and in conversations around the climate change, we continue to make the links and we continue to make the intersections around those two crises that we are looking at or we are experiencing in South Africa and in the region and globally. Thank you very much.
Thank you so much, Gqeberha. I think we must note that this entire year, the HIV story has been about about funding cuts. The HIV story has been about funding cuts. And now we're hearing that climate and climate change are making these shocks even harsher. And when you were talking, I wanted to say, is there any hope? Is there any hope? The funding cuts, the climate shocks are making it worse, but then you steered us towards hope and towards solutions and encouraged us to tell those solution stories. But still, I would like to ask, who needs to do what for those solution stories to be real and not just an idea?
So, Ida, I think you would know that in the past 30 years, HIV, a colleague of mine has said, has been the sexy girl in the room. In terms of funding, in terms of resources, and in terms of the response. And whilst globally and in South Africa, we were battling with high numbers of HIV infections, and our focus was to make sure that we control this pandemic, we then had to make HIV as a standalone program or as a vertical program that is standing alone as an HIV response. In the absence of funding, I think you've spoken about the funding crisis that the global health is facing at this point in time. And in the event that we are seeing polycrisis, in Africa, as we speak at the moment, we've got more than 30 outbreaks of different diseases, from Ebola to cholera to Marburg virus. So there's other crises that are taking place in the world. There's even outside the public health space, as we are talking now, climate crisis is an issue. Countries are battling with deaths. We need to look at debt relief programs. So countries, and including South Africa, we have other competing crises that we need to focus on. So as public health specialists, we have a responsibility of ensuring that we continue to ensure that HIV gets mainstreamed in the different conversations that are currently taking place. I know that in the Department of Health, there is work now that it started a couple of decades ago, but now is being fast-tracked to say, how do we integrate HIV into the broader public health system and public health services? How do we ensure that this HIV response becomes part of our daily key messages around prevention of diseases, becomes our daily conversations around how do you continue to take your non-communicable diseases treatment, like hypertension, like your diabetes and HIV? How then do we continue to promote a message of adherence, not only focusing on HIV, but integrating it to other systems? So HIV remains a crisis. HIV remains an ongoing pandemic. We are 30 years into it. And it's a different kind of pandemic because you as you are aware, other pandemics, we need minimum 2 to 3 years to address them, get to a solution, we vaccinate, we treat, and that pandemic will then stop being a pandemic. But HIV has been a pandemic for 30 years, and we're still battling with it. So in the crisis, in the global crisis that we are at, we have to continue to make sure that as much as HIV remains a priority, but we need to integrate it to other responses. We need to make sure that within the climate change financing, we find a way to make sure that health benefits, HIV response benefits, because it gets affected in the event of an outbreak. So as we all know that we have been battling with responding to the AIDS response, we were not meeting our targets. Then COVID came. COVID dragged us back like 5 years in the gains that we've made. Now we've got a global financing crisis. We've got a new challenge to say, how then do we continue making the AIDS response a priority, making sure that we continue to prevent new infections, making sure that as we also get to address other public health issues, you know that one of the critical crises that we have at the moment is teenage pregnancy. And as a result of teenage pregnancy, already that is telling us that our new HIV infections will continue to rise, because the minute you are pregnant, it means then you are engaged in unprotected sex, and your chance of acquiring HIV is also high. So as we address also teenage pregnancy, we have to make sure that we include HIV prevention. So our messaging has to grow. HIV is no longer a standalone response. It has to be incorporated in other global crises so that we can benefit from the new energy and the new agendas that are on the table at this moment.
Thank you. Yeah, not a standalone response. And I mean, our entire discussion is about two issues that don't stand alone, but in fact collide. So I wanted to ask you both, where is South Africa with regards to kind of really responding to this collision, or the impact that climate change has on health? Where is it on a policy level? You've given us really compelling data and information, human stories about both about climate change and about HIV and other health concerns. But as a country, we need to tackle this on a policy level. That is also a story that journalists would really want to do. So from where you sit, I'm sure you follow those discussions really closely. What is being done and what are the gaps, either of you? Perhaps let's start with you, Chris, sorry, and then also Kuteka.
Great, thanks. Yeah, I mean, I wanted to respond to Kuteka's comments as well. I think in terms of where South Africa is, I mean, certainly on the climate change side, we now have the Climate Change Act, of course, which pushes into priority developing plans to respond to climate change. So I will say, while the act is obviously really important, there, in many contexts, there have been existing policies and plans to deal with climate change. The intersection of climate change and health, again, is in there in some of the policies. It's certainly in there in the act. So at that higher level, people are recognizing the intersections, definitely. But as we know, the challenge is implementing policy. I think South Africa has generally had good policy. I mean, we can argue about that. But generally, we have the policy in place. The challenge is always in the implementation of that policy as it trickles down from national level down to region, provincial, down to metropolitan, etc. So the trick is, or the question is, how do we implement that policy? And if I can just quickly respond to the previous discussion, I think we can actually look at climate change in some ways as a positive. Yes, it exacerbates vulnerabilities, but it also shines a spotlight on existing vulnerabilities in the health system, in different systems. So in some ways we can use it. I mean, it's a bit of a macabre way of thinking about it, but in some ways we can use it to really highlight issues that have been there for a long time. And in South Africa, a lot of those issues fundamentally stem, of course, from the massive inequalities that we have in the country. So my hope is that as we take that Climate Change Act and as we think through what it means in different ministries, but also in different contexts in particular, we can actually use it to really shine a light on those existing vulnerabilities and inequalities, and then move towards finding solutions within those spaces. And to me, the really interesting thing is actually, can we do a lot more with a lot less funding if we look at it holistically? Yes, HIV, of course, has its own particular challenges and needs within the health system. But as we've both highlighted today, fundamentally a huge part of that is the social determinants of health. And that's relevant to HIV, it's relevant to flooding, it's relevant to food security, it's relevant to water security, urban water, livelihoods, all these different things intersect. And if we can start to solve some of these fundamental vulnerabilities and inequalities and challenges, we'll be addressing many of these sort of single sectoral challenges at the same time. And for me, the real hope there is the degree to which we can flip the conversation, the degree to which that conversation can be driven from the community level rather than from the top-down policy level. I think that's where the hope is. Thanks.
Thank you. What do you think, Bhekisisa?
Yes, as Chris has indicated, at a policy level, there's quite some work that has been done. And also within the Department of Health, there's quite work that has been done in terms of looking at adaptation policies, reinforcing policies, but they're still broader in terms of health. And I think one of the issues, I think Chris also has touched on this to say, how do we understand what these intersections are and these links are? And it seems like we are more focusing on infrastructure than on other issues that impact on the linkages. So we're looking at water supply, we're looking at electricity supply, we're looking at the actual infrastructure of the clinic, but we haven't looked beyond on the health system, on the actual building blocks of health system to say, how then do we respond to those in the event of a crisis? Are we able to provide a clinic service under a tent or in a school hall elsewhere that is not in that particular infrastructure? So I think those are the issues that we still need to look at. And then in terms of HIV itself, as you are aware that we have the South African National AIDS Council that has the responsibility to coordinate the AIDS response in the country, but also to coordinate different sectors that contribute to the AIDS response. So we still need to make sure that within those SANAC stakeholders, the new stakeholders, because if we want to continue the conversation around climate change, we need new stakeholders that the AIDS response has not worked with before. So we need to identify who those stakeholders are in terms of environmental affairs, in terms of your weather barrier services, in terms of your climate research, people like Chris. They need to be around the table or conversation table around those policy adaptations to make sure that they bring in that kind of conversations. So that is the work that still needs to be done to make sure that new stakeholders that also need to be around that table get into around the table so that they can then drive the conversation around issues of environmental changes, issues of predicting and be able to predict weather service, weather forecast, and what are these extreme weather mean, because heat, stroke, and floods challenges would not be the same and would not respond the same. So we need then to understand those issues. But I want to say provinces that have been much more vulnerable to weather crisis have adapted quicker. Your Eastern Cape, your Western Cape, and your KZN, which are provinces that have seen quite drastic weather changes, not necessarily as extreme as in other parts of the world, but extreme in that they shock the system in South Africa, because we are not used to those kind of weather extremes. You are already seeing those provinces having conversations within the health sector around adaptations and around system strengthening, compared to provinces that have not experienced any of the weather crisis. So I think the conversation has to continue. We have to continue the policy dialogue, but also in terms of we need to make sure that we have voices of our civil society organizations and as well as our journalists, so that they can then put the different institutions to account in terms of the progress. If they have not started, then they would need to start creating these structures that are then going to be able to create these cross collaborations in terms of us being able to address the crisis in an integrated approach.
Thank you very much. And I think you've both, Kokeka, you specifically answered some of the questions that we received from people who registered, and thank you so much for that. I'd actually like to ask you a follow-up question. One of the questions from, let me see who it's from Karen Upton was, are we seeing a similar impact on TB? Kokeka?
Definitely similar impact, but you would understand that the socioeconomic or the social determinants of health that drive HIV and TB are not exactly the same. So then there's some of the changes. But if you're looking at the broader impact around food insecurity, around treatment access, around displacement and the impact of displacement on your continuation of treatment, we see similar impact. But I think the difference is that, remember, TB is curable. So maximum, if you adhere on your treatment, you need 6 months on treatment and then you are cured. It is not like HIV that is a lifelong disease. But in terms of the disease impact or the disease crisis, we're looking at a similar situation. If you lose your TB drugs and you are already on month 3 or month 4, and then you are not on treatment for the next 2 months, by the time you get back to the health system, you might have a resistant strain of tuberculosis, and you might need to be then put on a different treatment regimen. We also know the stigma around TB, because we have a stigma around TB and poverty. So the more people that are TB exposed are then taken into poverty or taken into a less or drastic socioeconomic statuses, the stigma continues, and therefore then they don't adhere on their treatment as such. TB, we know that it spreads in dampness. So if we've then got heavy floods and heavy rains that then soak our homes, and then there's dampness, then if there's a TB or a person infected with TB in that home, or if there's a person with latent TB, then there is a higher chance of that TB being manifested into a disease that can then be spreading around amongst that community. We also know that our communities, when they get displaced, sometimes our response mechanisms, we will take people and put them in halls while we are waiting to put them in secure or in a much more structured homes. Staying in those halls, there's less ventilations, there's overcrowding. We might also be spreading TB during a climate change response, because that we take people to halls where they get to stay, it's wet, they don't have all their belongings. If one person or two people are infected with TB within that crowd that is in that hall, it can create an environment that can breed the bacilli quite quickly. So those are also the things that we need to think about, to say, also, as we are doing our emergency response plans, we need to think around that as we are protecting people from a climate crisis, but we don't put them in a situation where then they get exposed to a transmittable diseases like TB. So in environments where we put them, we need to make sure that there's proper ventilation. Those that are on treatment can still access treatment, but also we ensure that our non-pharmaceutical interventions that we learned during COVID continue to be implemented. You're washing hands, covering your mouth when you are coughing. So that's how we need to think, that either the crisis, the weather crisis, can contribute and exacerbate infections, or the infections can be exacerbated by the weather conditions. So we need to look at our response in both ways.
Sure. We've spoken about this collision of climate change and health concerns, but in a way, the solution can also be in it not being a collision, but a coming together of expertise and policy making around those two areas. You've said at top level there is discussion and acknowledgement of this collision and of the need for a coming together. But if you think of national policy and then provincial policy and then really the very much more local kind of where the rubber meets the road, as they say, where people are really feeling the impacts. Can you give us a picture, either of you, of how those discussions are filtering down, or alternatively also filtering up, so that people have the opportunity to explain or tell their stories of how one affects the other? So what I'm really asking is it just national level policy, or do you see other level discussions as well?
I mean, I can say from more on the climate change side, certainly it is trickling down to provincial level, to district level. Many provinces will have their own climate change strategy and action plans and so on, even down to district level. Many cities are also engaging with it. I think one of the challenges that we see is, even though there's engagement with it and often enthusiasm to engage with it, so often people are dealing with so many other challenges. So there are fundamental deficits in infrastructure and other service delivery. And now we're adding, by the way we're doing it in some ways, we're adding yet another thing to people's desks. So now you not only have to deal with your service delivery issue, but you also have to think about climate change. And you're thinking about finances, and you're thinking about reporting and the auditor report and all the rest of it. So we're adding another thing to the table. And I think that's often where things start breaking down, and we end up with tick boxing or check boxing. People saying, yes, I ran a workshop and we spoke about climate change, so we've ticked that box. So I think for me, the really important thing again comes to that issue I highlighted around governance. Like, what is governance? We're placing a lot of burden on the formal government to implement a lot of this, including in health, where the Department of Health has to carry a lot of this burden. And we need to be thinking beyond that, thinking broader. Who should be in the room? Who can help make decisions? Who can help implement these interventions? And it has to go beyond government, because honestly, I don't think government has the capacity in many cases to implement. And there are really exciting examples of public-private partnerships where private companies are getting involved. There's a lot of civil society organizations that are facilitating conversations, that are implementing things. It does come with its own complexities. We end up in these very complicated landscapes where everybody's doing little bits and pieces. So finding ways of coordinating that, I think, are really valuable. But I think fundamentally we have to be thinking beyond formal government if we want to really see progress in much of this. That would be my take.
Thank you. Kweka, I'd really love to ask you about a very specific example mentioned in one of your slides, because we've been saying that when people are displaced, often they get to a new health center, they're unknown. The service providers are unknown to them and they are unknown to that facility. And yet it can be solved so easily through a national identifier or a unique identifier, so that when I move from one province to another, I would be immediately recognized, even if I lost my ID book, and I can access ARVs, or whatever else I need to access. It's something that's been in pilot phase in South Africa for a very long time and still not implemented. Can you tell us a little more about that, and how that would help, and how journalists can also help tell that story?
So no, sorry, thanks very much, Ida. And I think we're all aware that our different provinces use different systems to capture their patients. So, and the systems are not even patient identifier systems. So if you move from one facility to the next, the system is not able to identify that is the same Ida that went to the clinic next door either this morning or yesterday. And there's been conversations around that we need a patient identifier system that is going to be able to track our patients. And we also have seen that this impacts even in our response, in our health response, because if you are HIV positive, you are on treatment for the next 3-4 years, then there's a disaster in your area, there's a climate crisis, your home gets washed away, your identification, your tablets, everything gets washed away. Your next best thing is to walk into a new health facility and get there to be a naive patient and coming for HIV testing. And you then register as a new patient. And it will be quicker for you to get medication that way than trying to explain that you don't have an identification, you don't have your last tablet tin, you don't have anything, you are just a person walking in and needing a tablet to take today because the last time you take your tablet was yesterday. So with the NHI conversations, the National Health Insurance conversations, issues around universal health coverage, they require that there is a proper patient identifier for you to be able to move within the public health system, but also that system needs to be integrated with the private health system. Because remember, NHI is combining the two health systems. So already the policy has been passed in terms of how that system would look like. So there are conversations now around the implementation of that policy. But as you are aware, it's a similar conversation that we are having now. Putting that kind of system into our healthcare system is not only a healthcare system requirement. We're going to require infrastructure. We're going to require the Department of Electricity. So we require other stakeholders to come on board to buy into the concept, the other government departments, so that we can then be able to drive the outcome of that. So I think Chris touched on it a little bit to say this, the governance and the financing around integration also needs to be looked into at a national level, because you will remember that at a national level, Treasury will then allocate budgets to different government departments who then cascade that budget in the same manner to the provinces, from province to district to municipality. So even if we're talking a district development model, which is what government has now been implementing across the districts in the country, in terms of talking about an integrated service delivery model. But the financing of that model is still sitting with different departments. And sometimes the priorities are not the same. We prioritize different things. We prioritize different areas within the same municipality. So water and sanitation would prioritize sub-district A, while housing is prioritizing sub-district C. So you'll find that houses are built, but they don't have water and electricity because those departments have prioritized other areas. So the concept around integrated service delivery planning and models we need to link that to governance as well as financing, and be able to pull it together, because we can all plan together. But if it's a requirement, we can plan all together, tick a box, we've got a DDM, and after that, we just go to our separate ways and do our service delivery priorities the way we've planned them. And some of the challenges that you might have, especially at municipality and district level, some of the competences sitting at national level are national competencies. For example, water and sanitation is a national competency. And the formatting changes. By the time you get to a municipality, there is Joburg Water Board, which is an entity that is sitting on the side that is not part of the broader planning systems and structures. So I think the issues around governance and district development models and service delivery, integrated service delivery planning models are conversations that needs to go broader and beyond national to say how is a province, how is a district, and how is a municipality configured compared to national, who can be able to sit together around the table with relevant stakeholders, but at a lower level are then not sitting, as well as issues around.
I know, I think we hear what you're saying, and this conversation has gone so quickly. I'm going to ask my colleague to post a poll, a Zoom poll in the chat, which we ask all of you who attended to fill out, please. And as you do that, I think there's hopefully a chance, if for those who want to stay, to ask a final question, a really great question from Arman Ujra, who is attending the webinar, who asked this question in advance. So I'm going to ask everybody who attended to please click and fill out the poll. But at the same time, I'm going to ask Arman's question and ask you both to very briefly say, what's your one actionable recommendation that South Africa could take now to build better and more climate resilient systems in the country? Give us your final words, each of you. And to those who attended, we will also email you a host of resources that Bhekisisa has on this intersection between climate and health. Stories which journalists have written, also resources for you to look at, where you can sort of find more story ideas on this, collision, as we've said, or also coming together of climate and health issues. And we really hope that this story remains on your news diary. So take it away, please, for that actionable item, please, to our two speakers. Thank you so much for being with us today.
Shall I jump in first? Yeah. I think for me, the actionable item is really to put in the effort to get people around the table. And we've all been talking about that a lot today, like getting all the people that need to be around the table in the room and having the difficult conversations about how we actually implement things. I think we've done so many of the high level things which are important. We've got the policies in place, but we need to have those difficult conversations. And sometimes they are difficult because sometimes it involves difficult trade-offs and different types of priorities and diverse perspectives. But we can't avoid those difficult conversations. So we need to have the courage to convene them, to have government in the room, civil society, have really good facilitators who can manage those kind of conversations and really thrash it out, figure out what this actually means and how we actually implement things. But just trying to do it through policy and more data and everything else, we're going to be going in circles forever. So thank you.
Gregor, what do you say? What's one actionable item for Gregor? I don't know if you're hearing. Is there one actionable item, Gregor, that can be taken? You're muted, by the way. What would this be?
Sorry about that. I was busy talking alone. So I think for me is the issue of holding institutions accountable. We have seen policy conversations and policy discussions. We have seen South Africa taking part at global platforms and global spaces, driving some of these challenges that we have and some of the conversations that we are having today. But at a country level, we don't have much conversations taking place. So I think for me is to drive the dialogues with different key stakeholders, is to support civil society in terms of capacitating them to have the information at hand, to then be able to hold our institutions accountable, able to hold our government accountable, to drive the conversations, to drive the policies that we have put in place to make sure that we continue to respond to the challenges that we have. We don't have a lot of time. 2030 is around the corner, and our AIDS response is not looking positive. Therefore, we have an obligation to make sure that we pull all the resources, stakeholders, as well as finances around the table to make sure that we don't lose the gains, but also we are able to make sure that we continue to provide a treatment for our people. Thanks.
Thank you so much. Thank you. I hope that the polling has worked out. I'm not very sure. My colleagues might be able to indicate. Otherwise, I know that we've come to the end of, it's already past 4 o'clock. But I just want to end by saying thank you so much, everybody, for joining. I hope you enjoyed the conversation. Thank you so much, Chris, Jack, Kokeka, Nogoduka. You are real experts in your field, and you've really made us think. And thank you for those really practical suggestions on how we can tell the story. Thanks very much.